Hi, thank you so much for being here. I know there are, 3 wonderful sessions this afternoon, but I'm happy that you guys chose to be here. My name is Ioana Stăiculescu, and I work with the Center for Health Policy, and I'm a project member in the Missouri Health Equity Collaborative. I'm really excited to facilitate this session. The panel is called Oral Health Disparities in Missouri. We're actually very lucky to have 3 of the leaders in oral health, in the oral health movement in Missouri here. There were a lot of things going on, and there are some other oral health meetings today, so we're really, really lucky to have everybody on the panel. And without further ado, it's my pleasure to introduce the first speaker. And we have Dr. Ray Storm, who's currently the state dental director for Department of Health and Senior Services in Missouri. Prior to his appointment to that position, he practiced general dentistry for 32 years in private practice in St. Peters, Missouri, graduated the University of Missouri in Columbia, and also UMKC School of Dentistry in Kansas City, and Linwood University in St. Charles, Missouri. He and his wife fostered the establishment of 2 nonprofit organizations for increasing access to dental care and oral health education, both globally and in Missouri. So I think we're really lucky to have today, and it's my pleasure to introduce Dr. Ray Storm. So thanks so much.
Well, it's my pleasure to be here. I'm really excited about being at a conference that's dealing with disparity and equity in health care in general, and also to include oral health. Oral health has now kind of become a little more elevated, I think, in the healthcare discussions, and so it's really good to see that coming around since I'm the new state dental director. I'm new in the position. I just started in December, and I can now find both of my offices, one in the Department of Social Services and one in Health and Senior Services, back in the catacombs of those buildings. So it's been kind of an interesting ride here for the first few months. But one of the things that I found when I first came into the position was that everyone kept asking me about data about the oral health status of Missouri. And so I went back to our group, the oral health programs, and asked them about it. Where can I get it all? Where is all of our information? I know we have lots of data, surely. And so we ended up having to start the process of bringing it all together into a burden report. And by the way, that burden report will be out in the middle of the summer in a printed form and on a website. So I think you'll be interested in seeing specific data for Missouri. My interest was, of course, to know where we are today, so I know where we need to plan to go in the future. So that's kind of the story about where I am right now. These are the panel objectives, and they're written in your program, so I don't think we really need to go through those objectives. My goal was to actually talk about the disparities in multiple areas, and then give you some of the numbers that maybe illustrate those areas, like race, ethnicity, age, geographic, educational, and income disparities, and how it relates to oral health. Whenever I look at numbers, I usually try to imagine what I think they ought to look like before I actually see what the numbers really balance out to. Now, this is information from our PSP program. That means Preventive Services Program. And this is numbers based on 72,000 children here in Missouri. So it's not a little tiny group that we were looking at. And this kind of floored me right off the bat, because I'm looking at race and ethnicity, and I'm thinking that I'm probably going to see kind of pretty much level at the same age. These are school-age children. It's like kindergarten through 3rd or 4th grade is the majority of these patients. I kind of expected all of them to be about the same, at the same level. Yes?
We're trying to figure out how to get those lights off so people can see better. Would you mind to read what the words are underneath the columns across the line?
Oh, absolutely. I'm sorry. It says on the left is African American. In the next one to the right is white. The next one is other races, and then finally Hispanic ethnicity. The numbers are for African American is 15%, and this is poor oral hygiene. So they're 14% or 15%, 19% for white, 21% for other races, and then Hispanic is 25%. So is it possible to turn the lights down just a little bit? So sorry. I'm going to have to change my format for my PowerPoints, aren't I? Oh, Matt, you can see that a little bit better now. Now, when I saw those numbers, I was sort of surprised because I honestly thought that children pretty much generally across the board at a particular age would probably have kind of similar oral hygiene. And in fact, as you can see, it didn't match up to be that way at all. Looking at age disparity, though, and Dr. Leary will be talking about this, I think, in greater detail, and that is when you look at the age breakdown, the columns all the way to the left is the 2 to 3-year-olds. Notice that they're a lot smaller, of course, than the 7 to 10-year-olds, and then they diminish as you go to the teenagers, and finally, when you get down to those 19, 20-year-olds, they really drop off the charts. But the big concern, and I kind of guesstimated this before I looked at these numbers, before they started coming in, and that was that the younger the child, the less preventive services they might be getting. And in fact, this proves that to be true, at least these numbers are panning in that direction. And this is the preventive services utilization rate. And by the way, this particular data is from the Department of Social Services. The Department of Social Services and looking at MoHealthNet, or the Medicaid dental services, and we're looking strictly at preventive services in this particular group of numbers. Looking further into the age disparity, we're looking here at, again, PSP program, the Preventive Services Program, and this is over mostly 2013, and it's, again, 72,000 children. You can see as we're looking at the kids, the 10-year or under 5-year-olds actually have the best of the oral hygiene. Again, that was kind of a surprising number to me. So the 2 to 3-year-olds are, in fact, seeing less preventive services, but at the same time, if they get up to about age 5, they have the better hygiene when you look at overall numbers. This also, our epidemiologist said, if you look at the male column in the middle, she said this also proves that high school boys are stinky. I thought that was kind of a cool observation. This is also looking at age disparity, but now we're looking at any permanent teeth removed because of tooth decay in Missouri. We're looking overall from age 18 to 24 up to age 65 years old. And as you can see, the numbers just constantly keep rising as you go up the age categories. And in fact, 80% of our population, by the time they get to 65 years old, have at least one or more teeth removed because of decay. Now, this is not third molars or wisdom teeth being removed, because we all have that, or for the most part, a majority of us do. This chart does show some race ethnicity breakdowns, though. The African Americans, they have the highest of the extraction numbers, and the Hispanics have the lowest of the extraction numbers, which again, that sort of surprised me, since if you remember here, the Hispanics had the worst oral hygiene. So it didn't quite match up, but in fact, that's what it's telling us, that the Hispanics have the least of the extractions. Now, we can pick the numbers apart, but we can do that at another time, but at least this is giving you an idea about data. I moved into here geographic disparity, and this chart is showing you where people, the numbers of people that are going to the dentist in the past year, and visits per year. And the purple color is the color that is the areas where the people have been to the dentist anywhere from 60 to 80% in the past year. Then the lighter color, blue, is, can't even see it on this particular monitor, 50 to 62%. The light green is 40 to 50%, and then the yellow is the 40% or less. And I call those the dental deserts of Missouri. You can see it's down here in the southern part of Missouri. There's 3 of them. But it all matches kind of the cities and the Highway 70 corridor that runs down between Kansas City and St. Louis, if you can see, and then a little bit in Cape Girardeau and a bit down in Springfield area. So that kind of just taking a picture of that one. That kind of shows where our care is happening in the state of Missouri and where people are gaining access to dental care. I call any place in Missouri a dental desert that doesn't have dental care. And I just threw these pictures in because this is a program that we do on an annual basis in inner city St. Louis. It's called Love the Neighborhood, and we do this in August. And what we do is we pass out about 20,000 pairs of tennis shoes and shoes to children to get them ready for school, as well as book bags that are full of all of the necessary supplies that they may need. But at the same time, we do a dental program too, where we do kind of like our PSP program, our Preventive Services program of education and a screening and also a fluoride varnish. And it's primarily parents that we're trying to educate. The children are picking up some of this stuff in school, so we try to go for the parents to help them to help their children advance the oral health. And this is in inner city St. Louis, so a lot of times I'm thinking that rural areas is where we're having the access issues, but it's anywhere in Missouri. You'll see the disparity for access any place in Missouri. This particular chart is designed to kind of show you where Medicaid patients receive their care. The breakdown on that, if you can see it at the bottom, is the urban areas are considered anything 200,000 or more. The basic areas are 50,000 to 200,000, and then the rural areas are 50,000 or less. So in the rural areas, and we'll just look at fee-for-service on the left, and this is fee-for-service Medicaid, 26% of the people, or about 26%, get their dental care in their own county. But about 43% get their care in just the adjacent county. And then 30%, or almost 30%, get their care in more than one county away. So they're traveling a great deal further. So this is kind of showing you how the rural system works, or the rural areas are. Then in the basic, it moves up where 47% of the people are getting their care in their own county. And then finally, in the urban areas, you're seeing 60% of the people getting their care in their own county, and it drops down to only 19% getting in non-adjacent counties. So in urban settings, they're more apt to being able to get their care in their own community or their own county as opposed to having to go to other counties. And this is utilization rate. This surprised me, and I think this might surprise you all too when you're looking at it. The column all the way to the left, if you can't see it, is the basic again. That's less than, or that's 50,000 to 199,000. Their utilization rate there's, we'll just look at the darker columns because I think you can see that better. It's at 26%. Now look at rural though. Utilization rate, that's less than 50,000. Their utilization rate is 27%, a little bit more. Then urban is less than that. So that almost contradicts what you're seeing in some of the other numbers. We're saying they can get their care in their own county, and yet we're seeing less utilization rate on a Medicaid level comparing those. So rural is actually the highest utilization rate for treatment services. And treatment services are defined as restorative care, extractions, crowns, bridges, root canals, things like that. That's treatment services as opposed to preventive services, which would be more like prophylaxis or cleanings, fluoride treatments, x-rays, examinations. Another geographic disparity that we see is in fluoridation. Now, I'm very excited about how well we're doing in the state of Missouri about community water fluoridation. We all know the benefits of that. We're ahead of the national average. You can see there that it's 76% of our population have community water fluoridation, where the national average is 74%. Unfortunately, we're still not quite to the Healthy People 2020 target, and maybe we'll get there if we keep working at it. But look at it on a map. This has a little bit different view. It concerns me. Again, it's like the I-70 corridor between Kansas City and St. Louis, and everybody north have the benefits of community water fluoridation. And it looks like if you live in southern Missouri, you're kind of in a dental desert when it comes to fluoride. This is kind of a surprise to me. I would have thought if we're 76% of the people in Missouri are having community water fluoridation, wouldn't that be sort of spread out all over the state to get that many? But in fact, that's not the case at all. It's mostly in our northern counties. So we need to address that, I think. Here's where I think we really need to work more than probably anything else, and Dr. Troutman even kind of alluded to that today in his presentation. This is a percentage of adults that visited the dentist in the last year in Missouri, and this is showing it on education and annual income. If you notice that as the education rises, the number of visits increase as well. So a college graduate, 77% of those end up going to the dentist. Less than high school, about 36% are actually going to have dental visits. It matches as well with the income. Less than $15,000 per year, only 37% of those make it to the dentist, and 50,000 or greater, 79%. Now the question has to be, why isn't it 100%? I understand that the 37%, but when you're starting to make more income, and they probably have more access to dental insurance, maybe access better to dental care, why is that not 100%, and why is it only 80%? So those are some numbers to look at there. Now let's look at just permanent teeth extracted due to decay. Just the opposite, or I guess an inverse relationship. Less than high school, 72% of the population have teeth removed because of decay. College graduate, only 30%. With annual income, again, same principle, same process. 63% of the population that makes less than $15,000, 63% end up having teeth removed. Kind of goes along with what you might be thinking. And 50,000 or greater income, about 35% end up having a tooth extracted. And in a similar light, I threw this one in. This is the percentage of adults 65 and older that have had all of their teeth removed. That's kind of a concern. Less than high school, 45% of our population end up losing all of their teeth. That's a pretty rough number, I think. With college graduates, we're down to 6% losing all of their teeth. So that's an area we need to be concerned about. Less than 15,000 population or income, 41% end up losing all of their teeth. $50,000 or greater income, only 12% lose all of their teeth. So it looks like kind of what Dr. Troutman was saying today. We're dealing with an education and we're dealing with an income problem more than an education problem of specifically oral health. So here's what I'm looking at in barriers for dental care. I'm seeing that the general education level and associated income levels seem to be the education part that we need to be really addressing, almost more than oral health education per se. I think we need to be addressing parent concerns about children's needs. When we're looking at the young child depends on the parent. So if the parent doesn't understand the importance, then the child doesn't get the care or doesn't get the preventive services and consequently starts off on the wrong foot. So we're dealing with a parent issue there. We have a general population concern about care needs. Obviously, if you make enough money and you have dental insurance, why are you not going to the dentist? So there's an issue there. We have a 20% of our population that don't take advantage of what they have available to them. Again, must be an education process or problem. And then our general population concerning the relationship of oral health to overall health. I think as people begin to understand the importance of that relationship, they take advantage of dental care and they seek out services. That would be what I would be kind of considering as a work direction for us. We have too few dentists in some counties. As we were showing you, when it comes to the Medicaid system especially, that gives us some of our numbers, and that is that the patients are having to move or go more than one county away in order to get their services. So that relates to or translates to that we don't have enough dentists in any particular county. We also have an aging dental workforce. Our dental workforce is getting older, like me, every day. And we are seeing more and more retiring. And consequently, we're not actually replacing them as fast as they're leaving the workforce. So we have a negative flow of dental providers. We also have too few dental providers for Medicaid services. There's a lot of issues around that. We don't need to get into all of those things, but we do not have enough dentists that are providing. And we have transportation issues from location to location, trying to get the patients to where they need to have the services provided. And here's some possible solutions that I might recommend us looking at. And this is a good group to kind of begin talking about that. We could increase the number of dentists, and I might say hygienists in each county, especially in the low number counties. The reason I say hygienist is that a bulk of our preventive services are actually provided by dental hygienists and not dentists. So we need to really work on that workforce. We need to increase the number of those dental hygienists that are in the workplace. One of the issues that we've seen here recently is at one of our local FQHCs, excuse me, one of our local FQHCs in St. Louis, when they put an ad in for a dental assistant, they will get 3 dental hygienists applying for the position because they don't have positions available in dental hygiene. So that's a workforce issue that we need to put into play because that's a way of increasing our access to dental care through those dental hygienists. We could increase our volunteer base of delivery. Delivery of care by volunteers, though, is difficult for sustainability. I've created a group called Give Kids a Smile. We're able to see lots and lots of children, but those numbers are dwindling because of us trying to keep the volunteers active in that process. We could increase Medicaid dental providers. A whole lot goes into that. We could associate community health centers with dental offices or dental community or local dental offices close to the community health centers. We could increase we could change the delivery model for dental care altogether. Good example of that is the virtual dental homes. If you Google Glassman virtual dental home, you'll see a totally different model for providing dental care. And I think it's really an opportunity for us to do that. We could change our education process, creating a womb-to-grave education to work for those people going to be 65 years old and thinking about losing all of their teeth. And finally, I think probably one of the best ways of creating some change is the Brookings Social Genome Project. Probably many of you are familiar with that, mapping pathways to the middle class. Again, 50,000, or they consider middle class 66,000 per year. If you can get people to that, can you not increase healthcare outcomes just by increasing or changing the number of people that do make it to middle class? So that's all I have to go by.
Thank you so much, Dr. Storm. And now is my pleasure. Our next speaker is Dr. Leary. Dr. Leary works at the Jordan Valley Community Health Center, and she's been there since 2007 and currently is the Pediatric Dental Director as well as the Associate Program Director for Lutheran Medical Center Pediatric Dental Program at Jordan Valley. She also supervises pediatric dental residents in both clinical and didactic portions of their residency, and also has an interest in dental public health, which includes access to dental care. So thank you very much for being here.
Thank you. Anyone that knows me knows I'm passionate about two things. One is the Iowa Hawkeyes, because I'm from Iowa. And the second one is that I'm really passionate about oral health. And so I'm going to spend a lot of time and go through a lot of things very fast. But if you have questions, don't hesitate to contact me. I'm more than happy to answer questions about oral health. So you've kind of heard what our objectives are for the panel, but I wanted to let you know I have some little spin on those objectives. I want you to understand how federally qualified health centers help people access dental care. I want you to understand the problem of dental decay from a pediatric perspective. And finally, how we can help healthcare providers work together to prevent dental caries. And I need to thank a couple of people for these slides. First is Dr. Craig Hollander, who's a pediatric dentist over in St. Louis, he's the authority on pediatric dentistry here in the state. We all look to him for guidance. And also Ms. Karen Dent from the Missouri Primary Care Association. So I want to start by talking a little bit about health centers. Some of you are familiar with health centers, some of you may not be. So I'm going to kind of give you a Health Center 101 primer. Federally qualified health centers are locally driven, comprehensive primary care and disease prevention health centers. We serve low-income populations and medically underserved urban and rural communities, and we tailor our services to the needs of the community. So kind of the mantra in public health is you've seen one health center, you've seen one health center. We're all very unique. We receive federal funding at the beginning or the initiation of our program, and then a small amount to offset the costs in subsequent years. So most of the financial gains that we get come from providing care to patients. The financial funding that we get at the initiation helps care for the uninsured patients that we see. So a little bit about us. We have to provide or arrange for comprehensive care, including physicians, nurses, lab, x-ray, pharmacy, dental, mental health, and anything else under EPSDT. And oral health is a big part of the EPSDT, which is early periodic screening, diagnosis, and treatment. So that is something that is federally mandated, that children have access to dental care. Physicians in our health centers have to be board eligible or certified. Dentists have to be licensed in the state. So unlike the VA system or Indian Health Services, we have to have a license here in the state of Missouri in order to practice in a health center here. Centers have a formal relationship with the hospitals, including admitting privileges, and we're required to submit comprehensive health plans for our geographic areas, detailing how we're going to provide services, what kind of needs we have, and what are the impacts of our interventions. And we're required to have audit compliance for these things. And finally, we have agency-wide audits that are required and submitted annually to the federal government. So where are these FQHCs? Well, we are really have a mission to serve the medically underserved population. So we may be in geographically isolated, either urban areas, which Dr. Storm talked about, or rural areas. We serve the uninsured and underinsured, low-income, migratory populations, and I don't have in there, but also homeless populations as well. But we also serve the entire community, those on Medicaid, those through a sliding fee scale, those that are self-pay, and private insurance. In the United States, there are over 1,100 federally qualified health centers, and over 17 million people have found their health care in health centers. This creates jobs within the communities. In Missouri, our organizing body is the Primary Care Association, and there are over 21 health care centers in over 95 communities. And I just want to point out that we talk about our medical, our mental health, and our dental services. And we have served over 160,000 patients in the state, and it provided over 343,000 dental encounters. So anytime somebody goes to the dentist, they tend to go at least once to twice a year, and we're seeing these patients again and again. We're not urgent care centers or free clinics, but we want people to establish primary care and find a medical home. It's integrated dental, mental, and medical care at the inception. So we work not in a silo. We work together as an organization. And we work within the state and the community. From an oral health side, we're helping to train some of the new dentists in the state. We work with A.T. Still University, Southern Illinois University, UMKC, providing education opportunities for students, also with the hygiene schools and the dental assisting schools. And then we work with all sorts of organizations within the state, Head Start, WIC, oncology programs, Boys and Girls Clubs. So you name it, we tend to work with them. So that's a little bit about federally qualified health centers to kind of give you a primer. But now I want to talk about dental decay, or little teeth, big problems. So my husband cracks up because every time I give a presentation, I start every presentation the same. I want to talk to you about what the Surgeon General has found about oral health in America. And dental caries or cavities, I'm going to use those two terms interchangeably, is the most common chronic childhood disease. It's 5 times more common than asthma and 7 times more common than hay fever. And if you are not a dentist, let me tell you, these big holes in the teeth are not normal. So I always laugh because we have all these asthma grants out there, and Dr. Troutman talked about asthma, but why are we spending all this time on asthma when this is what I'm seeing every day? 80% of dental caries is found in about 20 to 25% of the children. That's not new to anyone, the 80-20 rule. And about a little less than 30% of children between the ages of 2 and 5 have visible decay. And that is the reality that I live in. Poor oral health in America causes children to lose 51 million school hours each year due to dental-related reasons. And this is a big issue for school systems because they're getting paid for students being in school. And almost 80% of tooth decay in the poor children in the United States is untreated. And this is also something that we're dealing with. 4 to 5 million children have tooth decay that interferes with routine activities like eating, speaking, sleeping, attending school. This is a child who has a very obvious facial infection due to dental decay. What this child has bought himself is 3 days in the hospital with IV antibiotics, a trip to the operating room to get the tooth removed, and some other health consequences from that. So this is very expensive to treat. And this is kind of our call to action as pediatric dentists. This is Diamante Driver, who passed away in 2007 from a brain abscess. This 12-year-old boy, he's 12 years old, he had a toothache that he kind of underreported to his family. His family had other challenges. And so he had a brain abscess. He went to the operating room. They were able to open up that area, and they cultured the abscess area in the brain and found out that it was the same organisms that are found in dental decay. And so he died in 2007. His family has been very adamant about getting kids care. But what's sad is that an $80 extraction could have saved his life. And there's other Diamantes out there. So in healthcare research, we talk about assessment and evidence-based information. And so the question is, why does caries risk assessment need to occur so early? Well, we know from experience 2 is too late to start this process of providing information. So some of you may have heard of the terms baby bottle tooth decay, bottle rot, nursing caries. Those are great. That's great descriptors of the problem, but developing countries with high caries rate and no bottles are just as susceptible to dental decay. And more than 40% of children have tooth decay by the time they reach kindergarten. So as pediatric dentists, we say that anybody who has a cavity and they're under age 6, it's considered early childhood caries. Those children are not able to brush their teeth on their own or do things for themselves. So we're going to call it early childhood caries. Any sign of a smooth surface cavity on a child under the age of 3 is defined as severe early childhood caries. And you're probably like, what is a smooth surface caries or a smooth surface cavity? But that is a cavity on a front tooth or in between the back teeth. So this child is 2 years old. And I know that because they're missing their 2-year-old molars. And I know you're not oral health professionals, but those don't look right. And so this child is suffering from severe early childhood caries. And this is a 3-year-old who's going to the dentist for the first time. And you notice his big old facial swelling here. Unfortunately, his first trip to the dentist is to get a tooth out. And that's not a fun way to start your experience of going to the dentist. So what happens is that these children need to be seen in an operating room setting. And the typical cost of the dental care alone is $1,500 to $2,500 for the dental fees. That's just dental. But there's also an outpatient facility fee, which is about $2,000 to $3,000, and about $8,000 to $10,000 if we're seeing these patients in a hospital setting because they have some sort of special health care need to go with them. And what's really painful is that there's risk, there's trauma, and there's great expense, but this is 100% preventable disease. And I see this about 12 times a week. We treat an average of 11.7 teeth per patient that I see, and there's 20 teeth in a kid's mouth. And the average age is 3.4. So this is what I'm seeing every day in my clinic. And what's the cost to the state? There's a cost to the patient, but the cost to the state is even greater. And there's a great study done out of the University of Iowa back in 2000 where they found that less than 2% of children enrolled in dental Medicaid accounted for, under the age of 6, accounted for over 25% of the dental dollars spent. So we're spending a whole lot of money on mouths like this when it could have been prevented to begin with. So it's kind of going back to Dr. Troutman's analogy. Let's go back to the beginning of the river and find out why this is happening. So this is just a glance in my life. These are abscessed teeth, and it doesn't take a dentist to realize that that's not normal. These brown, that's teeth. Those should be nice and pearly white. So what's the cost to the child? Well, they can't eat, they can't sleep, they don't gain weight the way they're supposed to. It's costly to treat. It affects their permanent teeth. They have poor sleep habits. They can't learn. These kids have a toothache all the time, and they can't tell a parent that I've got a toothache. They just act out in behaviors. So I wanted to talk a little bit about how cavities develop, and I'll be very quick. My son was spending time going over this presentation with me, and he was very excited by this Venn diagram. And so first of all, it takes a tooth and it takes a tooth in a person's mouth to cause a cavity. If you don't have teeth, you can't have cavities. So those babies with no teeth don't have cavities yet. The second thing is that it takes a bacteria that causes cavity, and that is transmitted from the primary caregiver of the child to the child. So if mother has bad teeth or dad has bad teeth, kids are more likely to have bad teeth because they're passing that bacteria. So when we don't cover things like adult dental Medicaid, or we don't cover pregnant women are covered right now in Medicaid, but not just regular adults, then that is making our children more susceptible to dental cavities. Third thing is the refined carbohydrates, or what kids are eating. And the things that you think are not such a big deal, like goldfish crackers and Cheerios and bread, those things stick to a kid's teeth. And so that is more likely to help cause cavities. And we won't even get into things like fruit snacks, which there is no fruit in, and raisins and things like that. And the final thing is the time that the plaque sits on the teeth. So as kids have more plaque on their teeth, more time, they're more susceptible to getting cavities. So if we don't teach people how to brush their teeth, that becomes an issue. So how can healthcare providers work together? Well, like Dr. Storm said, we don't have a lot of Medicaid providers. And I want to point out that even though only about 8% of children in the state may be uninsured, that rate is much higher for dental, because dental insurance, even through the Affordable Care Act, which is an essential health benefit for children, that doesn't mean parents are buying the dental insurance. In general, the public spends about 20% of pediatric healthcare dollars on children's dental services, but less than that is given to kids on Medicaid. And in 2012, only about 17% of fee-for-service and only 4% of managed care children to and under received Medicaid dental services. And there's only a few dentists that accept Medicaid, and the people that do may not want to see the very young, the problems that I'm seeing. There's only about 62 pediatric dentists in the whole state, and there's 2 residency programs, one in Kansas City, which graduates 2 or 3 pediatric dentists a year, and 4 in Springfield. We'll have our first class next year. So we're not the only providers, oral health providers, that can provide anticipatory guidance and prevention, and collaboration does make a difference. And we're requesting that pediatricians and pediatric health care providers get the knowledge base to perform oral health risk assessments beginning at about 6 months of age. That's when the first tooth comes in. And where there's providers unwilling or unable, Dr. Canellis, one of my mentors, says that we should train other people, hygienists, WIC nutritionists, Head Start workers, to do this anticipatory guidance, provide these screening exams, and place fluoride varnish. And you may not need a separate appointment. On your way to the tonsils, pediatricians, take a look at those white things that stand out in front of that. The point is a dental home, and we want all kids to have a dental home by 6 months after the eruption of the first tooth that is comprehensive, continually accessible, coordinated, and family-centered. And our recommendations are immediate referral for infants with a dental problem due to trauma or disease, and then examination at no later than age 1. And use evidence-based anticipatory guidance models. There's several out there, the AAP, AAPD, Canberra, ADA. So there's all sorts of different anticipatory guidance models. So what does the state of Missouri look like? Well, less than 30% of kids get care, but what's great about this state is the Missouri Health Net allows primary care providers to bill for fluoride varnish. And that's something that's been around for over 30 years in Canada and Europe. It's been shown to prevent and arrest dental decay. It's dramatic reduction in cavities, and it's comparable to other traditional topical fluorides, like when you put those trays in your mouth with that foam. We don't do that anymore. We paint the teeth, and it's much easier. It can be applied in any setting. But the one thing you have to know is it's an off-brand use of the product, and I think I have a disclosure about that. It's an off-brand use, but it's reported over and over and over again, and there are many different states that have models for utilizing this. The big thing that I want to bring out, what we can do to help affect this, is collaboration. You know, I'm really lucky. I work in an interdisciplinary care environment. I have Jackie Morris here from our clinic, and she is our integration specialist. So she helps make sure that my patients in dental are also seen in medical, but vice versa, medical to dental, and that they get access to mental health if they need it as well. But things like the Points of Life connects children with dentists through their primary care providers is a great opportunity to collaborate in the private sector community. And we want to recognize the dental providers who see these young patients and also the medical providers that are getting patients into the area. So this is a great way to collaborate. And I'll take questions at the end. I have to have my obligatory Hawkeye thing, but I get questions all the time about this. And if you can't read it, it says put some of that sweet tea in my sippy cup. And this is something that I'm dealing with every day in Southwest Missouri. I'm from Iowa. We didn't have sweet tea, and I didn't know that you give a kid sweet tea, but to have that on the back of a high chair, that's a public health concern to me. And so I no longer frequent this restaurant because they don't think that they need to take this out. But it is something that you need to think about as public health providers, that the decay process is multifactorial, and there are many different things playing a role in this. So I'll take any questions in a minute, but I do want to point out that we do have some handouts. A lot of these came from the state and also from maternal child health, so they were free to me. You can get them too online. Also information about the Points of Light program through the Missouri Academy of Pediatric Dentistry. Thank you.
Thank you so much, Dr. Leary. And if it's okay with everybody, we're going to take questions at the end. That's okay. Now it's my pleasure to welcome our next speaker, which is Mr. Gary Harbison, he's the Executive Director of the Missouri Coalition for Oral Health. He had previously worked as the chief of the Bureau of Special Needs, Special Healthcare Needs with the Missouri Department of Health and Senior Services, a position he has held for over 7 years. In this position, he has also he's also designated as the Maternal and Child Health Title V Director of Special Healthcare Needs for the state of Missouri. Welcome, Mr. Harbison.
Very good. Well, I'm going to talk to you about the coalition, which is an organization dedicated to dealing with some of these challenges that we've been talking about for the past several minutes. I'm just going to talk a little bit about why we exist, our mission and our vision, how we're structured, a little bit of our history, who we are, and then most importantly, our policy work. We've already heard a lot of data and a lot of very good data on, particularly on disparities. One of the things the coalition has identified as a need is having more information about data in Missouri, and fortunately, we're starting to see that. But some of the bigger picture things I wanted to go over real quickly. The reason we exist is oral health in Missouri is poor. By and large, all of the numbers we have available to us say bad things about the state. We're 47th among states in access to oral health care. Pew Charitable Trust gives us a C for children's oral health and a D for use of dental sealants. 63% of Missouri Medicaid enrolled children received no dental care. That's the latest data we have. And then we know from a little study that was done by Health and Senior Services several years ago that 44% of skilled nursing facilities residents had untreated decay. So these are bad things. There was also a great MSN Health article in 2012. They took a variety of data points and kind of put them together in a ranking. And the city of St. Louis had the worst oral health of any American city, and Kansas City got 9th worst. So we're really doing a great job there. More importantly, and this has been important data to have, and again, I have to thank Health and Senior Services because they did a great job getting this information together. We're seeing an increasing use of emergency rooms due to dental conditions. This has been going on. It's a big trend for several years. It's happening elsewhere in the country, but it's great to have Missouri data, $17.6 million spent in ERs. And you have to realize this is really not like they go in there and they get dental care. What they get is stuff that's palliative at best. They're going to get some pain medications. They're going to be sent home. And if they don't go get treatment, which chances are they're not able to, they're going to show up in the emergency room again. So a lot of wasted money. So Medicaid adult dental benefits ended in 2005. There are some exceptions to that. Eligible pregnant women, persons accessing the Blind Pension Fund, and nursing home residents. And only about 11% of dentists licensed in Missouri participate in Medicaid. So to kind of sum up, and this is very consistent with the things that we've heard from the other two speakers, oral diseases are a devastating problem among a significant percentage of Missouri's residents, affecting their overall health and ability to work and learn. Access to oral health care varies greatly across the state. We've seen emphasized if you're in certain rural areas, you're going to have a hard time getting care, and it's also true in some of the urban areas where there are challenges. Poor oral health is linked to heart disease, diabetes, stroke, premature birth, and dementia, and it seems that every time a new journal comes out, there's yet another article linking it to some other physical health condition. I do want to say that's not necessarily causal, but if you have heart disease and you also have poor oral health, those two things are going to play off of each other and make your overall health worse. Oral diseases affect individuals, families, and communities and can contribute to lower academic achievement. We had heard some specific about that. If you're in pain, you're not going to go to school ready to learn. And poor oral health can make it difficult to get a job and to keep a job. So it's really a very important issue. It is kind of a back burner issue in the healthcare system, much like mental health is. It's thought of as a separate side thing that you can kind of forget about. Fortunately, we are seeing some great work, particularly in Missouri's FQHCs, to do more integrative work. So the mission of the coalition is to improve the oral health for all Missourians through sound public policy and public awareness. And our vision is that oral health would be a high priority for all Missourians. That would include individuals and policymakers. And we've worked to go after those two things. Just real quickly, what the coalition is: we are a 501c3. We have organizational and individual members. We've got a 12-member board of directors with an executive committee. I'm the executive director. We're run by bylaws. We've got a strategic plan. And the most important thing you can learn about the coalition is we set our policy agenda by consensus. So we have to agree on things, and we tend to not go after controversial issues that we can't agree on. And in fact, any one of our board members can veto a particular item. That's good because there's so much work that has to be done in oral health. We don't need to be spending time beating each other over the head about controversial issues. And I think that's playing out very well. We were reorganized in 2011 to focus on oral health. The coalition's been around for a number of years. It actually failed previously because there were serious disagreements and no explicit understanding on how to address those. So we're funded by memberships, donations, the Healthcare Foundation of Greater Kansas City, the Reach Healthcare Foundation, and the Missouri Foundation for Health. This is some of the organizations. I know with this display that's probably more frustrating than anything else to look at, but you can see very broad-based group of collaborators: the Missouri Dental Association, the Primary Care Association, the Missouri chapter of the American Dental Hygienist Association, the dental school at UMKC, ATSU's new Missouri School of Dentistry and Oral Health, Health and Senior Services, Mental Health, very broad-based, a lot of clinics in there, Delta Dental, DentaQuest. And this is our board, or at least most of them. This was taken at our conference that was held in late February, and you can see that Dr. Leary is in fact on our board, so she's a plant to support the coalition in this presentation. That was the first, to our knowledge, the first conference held in Missouri that was focused on oral health policy. We think it was a great success and helped raise awareness. So we have then, the past 2 years, been working on a variety of consensus-derived policy issues. And one of the things that we have achieved is we went after an oral health caucus. We found out there were House rules, new House rules that meant the word caucus was only applied to the parties. So it's actually an oral health issue development committee in the General Assembly, which is great because it's a standing House committee. That means it comes back year after year. It started in 2013 and has been active this session. Donna Lichtenegger, Republican from Southeast Missouri, chairs that group, and Jeannie Kirkton, a Democrat from the St. Louis area, is the vice chair. They have a written purpose. Since you may not be able to read it up there, I'll do it. The purpose of their oral health issue, IDC, is to raise government and public awareness of the oral health status of Missouri and to recommend and work toward legislative and budget solutions to improve the oral health of Missouri citizens. And so it's looked at a variety of topics. Early on in the 2013 session at the first meeting, there was a great discussion about the role of the state dental director, and I'll talk a little bit more about that in a moment. We had 5 dental directors from around the country call into that meeting. We've talked about work to increase local access to oral health services and work of local coalitions and a variety of other topics. One of our other goals was to reinstate the Missouri dental director, and I think Dr. Starm's presence has proven that we've done that. In fact, we were very delighted to see him appointed to that job and start in 2013. We went down multiple tracks after that policy goal. The key turned out to be a public-private partnership. There were private funds provided through Delta Dental of Missouri, Missouri Foundation for Health, and Reach Healthcare Foundation, and that pushed us over the edge, and we moved forward with that. And as he mentioned, there's a lot of work going on with the state now around oral health projects. We're very glad to see all of that work going on, and it's also important that Missouri actually has not been eligible for certain federal grants, oral health grants, because we didn't have a dental director. Well, now we do, so we can be competitive for that. We also wanted to see the expansion of access to dental sealants for children without routine dental care. That is now a project of Department of Health and Senior Services, and we look forward to Missouri no longer being one of only 4 states without a sealants program. Those are things that we have accomplished on the policy agenda, but we're also working on additional things. Probably the biggest of which is reinstatement of a dental benefit for adults under Mo Health Net or Missouri Medicaid. That is, in fact, in the budget. It was recommended by the House Appropriations for Health, Mental Health, and Social Services Committee. It went to the House Budget Committee. They supported that. It was voted on to the full House. It went to the Senate. They agreed on the amount. There are some language differences. The House went for reinstatement of the exact package prior to the 2005 cuts. The Senate wants to do a fairly robust package, but not the exact package of services, and they want to raise provider rates. These differences will be worked out in committee. We think it's a win either way. Reinstatement, straight out reinstatement, as the House spoke about, would do little to increase access because provider rates in Missouri are extremely poor. So we think the Senate proposal is a good proposal. I put $46 million state and federal. Actually, it's $48 million. So that's new money that will fund services for adults in Medicaid for dental care. I have to say, 2 years ago when we worked on our policy agenda initially, we wouldn't even put adult dental on the policy agenda. We thought it was a non-starter and bad for what was effectively a new organization to have out there. It would be a difficult thing to get any movement on. And we added it to our policy agenda last year because we had continued to work on oral health and started to see some movement in that direction. It's quite remarkable. It's remarkable in a context in which Medicaid expansion will not happen, as many people have sworn, unfortunately. And so we're very glad to see that. It's really good for the state of Missouri. It's really good for adults on Medicaid. We've also worked on protection and expansion of public water system fluoridation. We think this is a great thing because it supports the oral health of all community members. If you live there, you get the benefits of fluoridated water. The science is quite solid on that. If you dabble in public health very long, you will run into people who think fluoride is poisonous. If you'd like to see some of those lies, you may go to the web and do a search, and probably the first 7 or 8 links you pull up will be talking about how horrible fluoride is. That's all foolishness. I hope to not offend anyone here if we got any anti-fluoride folks in the room, but our primary role is to support the work of local advocates. It's very much a local decision and a local topic, not something. We do not have a statewide mechanism for telling a community to have or not have fluoride. We have supported successes in Columbia, Forsyth, and St. Peter's. As you saw earlier, Missouri is pretty good when we're compared nationally. 76% of the people that are on public water supplies in Missouri are getting fluoridated water, so that's really good and compares favorably nationally. However, what we've seen since the recession is a trend of communities trying to save money, and maybe their equipment's getting old, and so they discontinue fluoride. There are anti-fluoridation people in Missouri working on this. They're active right now. There's a couple of communities where this issue is coming up again. And we'll fight to against that with local advocates. We do have an important tool out on our website, Water Fluoridation, a Community Toolkit to support the work of local advocates. And we also have House Bill 1078. Well, it's actually House Committee substitute for House Bill 1078. It's been modified. It has passed the House. It's gone on to the Senate side. It's had first and second read, for those of you who know legislative processes. It has been assigned to committee, and there will be a hearing on Tuesday at which at least the Coalition and the Missouri Dental Association and the hygienist, well, those two will testify. The hygienist, I think, will not have someone to testify, but they'll submit written support. We do not see a lot of opposition to that bill, and so we're looking forward to see it passed. It is a moderate bill. What it does is requires a community that currently has fluoridation to give notice to their customers and to the Department of Health and Senior Services and to DNR, the regulatory agency for fluoridation, at least 90 days prior to a meeting at which they may decide to discontinue fluoride. It's been gotten support through the whole thing. It's been toughened up. Now there's a component that says, well, if you discontinue fluoride without going through that process, you have to put it back in and then do notification. So really great thing. We tailored it to fit the political context in Missouri because we've gotten support. Some people have said to me, well, we should just go for a statewide mandate. I believe it wouldn't even get off the ground in Missouri in the context. But the way this works, it supports fluoridation, gives local advocates an opportunity to mount a defense. And we think we'll win doing that, as we have in many communities. So we have some coalition material over here for you. I would like to thank you all for coming in here and being interested in oral health. It is, as I said, it tends to be a sidebar issue, both in the policy realm and to people individually as they think about health and healthcare systems. So I'm very glad you all came in here. If you're not a member of the coalition, I would very much like you to join the coalition. There's information on that over there as well. And we're on Facebook and Twitter, and we're pretty entertaining. So that's what I have.
Thank you very much. And now I think we have around 10, 12 minutes for questions.
There are many private practice dentists who do not do Medicaid, who do participate in things like the Mission of Mercy that's coming up at the end of next week, and do those types of programs. I think when it becomes a little bit more reasonable financially for them to participate, there will be certain dentists that will join. There are other issues for dentists, as I understand it, and I should say I'm not a dental professional and I don't play one on television either. But I've talked to a lot of people. I should, yeah. But there are administrative issues with Medicaid, particularly on the fee-for-service side, that have been problematic for private practice dentists. Those issues will remain. So it's not an automatic win, but I think it gives a good foundation for us to see some movement forward. The other thing I'd say about the coalition overall is, we have momentum now. Oral health is being paid more attention to. People are talking about it. And I think reinstatement of adult dental with a rate increase is going to make a lot of people pay attention to oral health, and I think that creates awareness, and I think that's true for the provider community as well.
Very big win. Congratulations.
Well, it's not done yet. It will have to be passed, sent to the governor, and the governor will have to sign it. So, yeah, we feel great about it, but we do want to see it completed and actually implemented.
I'd like to address that just one moment, if I could. In Montana, they raised the fees paid to dentists, and the provider rate went up to 90% of the eligible dentists practicing in Montana started providing. So the numbers do play out, that if you do raise fees, you do get dental providers.
How much they raised them?
They actually went to 70%. They treated themselves like a dental insurance company, like Delta Dental or something like that, so they used those kind of rates. There's no competition for the poor. No one is out there competing. But if you raise those fees, there is competition for the poor. So they go and market for those patients.
So
Yeah.
from my perspective, you ask about policy things, and I think there's two things. First of all, Medicaid currently covers children. 21, well, it depends. But anyway, 19 to 21, sometimes when they're special needs, I end up calling Jackie daily to ask her, especially about my special needs patients. But, you know, when you start seeing kids that look like what I do, and there's only 62 of us in the whole state, that really scares a lot of dentists off because they think, what am I going to do when I see that kid? Because I can't abandon this patient and I can't treat them either. And one of the unique things that we have in our area is that we have relationships with those other private practitioners. Hey, you see the regular 1-year-old who's just going to cry and scream and cause all sorts of havoc in your office, and you brush their teeth and you fluoride them and you provide the anticipatory guidance. And if you get into a situation where you see those kinds of mouths, you have a place to send them. And so that is one of the things that I think that really helps from a policy standpoint is when we have those providers out there like me and the people that work in my clinic that are willing to take on those more difficult cases. The other thing is that training, I think, is a big part of this, and this goes back to our educational and dental school training. You're not going to want to see a patient who is not like you if you have never been in that environment. So I come from a family of dentists. Oral health is a really big part of my life, and it was a part of my family's lives. But I spent 10 weeks in an extramural program, 5 weeks in an urban area in Des Moines, Iowa. Some of you from St. Louis or Kansas City may not find that to be urban, but it was urban to me. With patients that were illiterate, didn't speak the language, used an X because they didn't know how to sign their name. That was a real education for me. I went to Indian Health Services in Montana and treated a whole different population, and I spent 10 weeks doing that and realized this is what I could make as my career. And I think there's a push in the educational systems to do that now, and that's why we have programs with UMKC, AT Still, SIU, to send those students to us. So it may not necessarily be that they decide to make it their career. I would love that. But they may understand what's out there and be willing to participate in their communities.
Thank you. Mari?
My question has to do with the adequacy of our professional workforce in Missouri and the policy issues related to that. Where do we rank in terms of number of dentists per person in the state? Do we know that? And is what if anything do we need to be doing to bring more dentists, train more dentists, get more dentists to stay here? What are the issues and how should we be addressing them?
Well, just about 2 years ago, they raised the number of students that they're bringing into UMKC School of Dentistry, which is increasing then the number of potential graduates. And then now you have AT Still, the new dental school there as well in Kirksville. So we'll be seeing a higher rate of the number of dentists being trained. But in addition to that, the AT Still Dental School directs those students more into public health service. So we're having a larger number of public health oriented students that are graduating from the dental program. So I see that as one way of addressing the issues that you're just describing.
Do we have a sense of what the gap is, how many we need, and whether these programs are going to help us get to the average?
Actually, that's interesting that you're saying that because we just started working on those numbers this past week at the Department of Health and Senior Services. I approached the public health portion of public health or Health and Senior Services and asked them if they could run those numbers. So we actually started addressing those numbers just this past week. So we're in the early stages. We're quite a ways off, but it's by county. Some counties were doing great, and some counties were doing very poorly. But I can give you a lot more information soon about that. I mean, and real numbers.
Another great advantage to having a dental director in Missouri for the first time in over 10 years. So we can look at stuff like that.
Yeah.
And to add to that, I think one thing that you have to remember, and especially those of you from rural communities, I was from a rural community and then I moved out of state, but you're more likely to get a dentist in your area that has graduated from high school in your area, or whose spouse has graduated from high school in that area. So it's mentoring those young dentists, and or those young people now to become dentists. You don't decide when you're 22 or 23 years old, hey, I want to be a dentist and move back to West Plains, Missouri. You decide when you're in 6th and 7th grade, when your science teacher says, hey, you're really good at this and you're good with people, and your local dentist says, hey, you'd be a really good dentist and you should think about taking over my practice in 10-15 years. So I think that's one of the things that you need to recognize and realize about recruitment and retention of dentists. And the other thing is a financial thing. It's really hard to think about going to an area if you don't think you can get paid in that area. And when people like the state say, I'm going to give you a loan repayment if you agree to provide care to a segment of the population in a community that we have designated a health professional shortage area, and that can be even in inner city St. Louis and inner city Kansas City, then students are more likely to go to those areas and provide the care. And we've seen that in medicine, and we've seen that in dentistry as well.
Thank you.
AT still is making a pointed effort to get at least some of their students that are from these underserved areas, with kind of reinforcing what you're saying, to get people to go back there. I would also say, kind of as an outside observer about dentistry, there's a great deal of variability between many of the older dentists and the newer, younger dentists. There's a greater likelihood, I think, to work in clinic settings and to consider that to be a good route to go. Whereas, many, I think, older dentists they've been educated and trained in the private practice model and in running a business, and that's kind of their orientation. But we're seeing, I think, a shift in the workforce already.
Thank you so much. I think it's 11:30, so I think this is when lunch is going to happen. If it's okay with everybody, we can. Do you want another question? Maybe do we do it? I have some. Yeah, I'm going to remind people. I have a question from here, so let's try the last one question.
Okay, I just wanted to point out that my county, Callaway County, has been working on this for about 5 years, and we have an FQHC now. We're doing really great.
Yeah.
But there's a huge cultural thing going on that needs to be addressed. It's not necessarily educational, it's cultural. You have generations of families that have not gone to the dentist.
Yeah.
And do not go. It's not part of their family culture to go to the dentist. And that needs to be addressed as much as anything else. And it needs to start with the kids and then work towards the adults. But we've got to start that culture of it's normal to go to the dentist, just the way it's normal to go to the doctor. And we're missing that piece with our families. We're really missing it.
Is there anything that you've tried? I'm sorry to interrupt you. Is there anything you've tried so far in Callaway County?
Oh, we've tried education. We've put stuff out, and the FQHC is advertising constantly. But we started out really grassroots, and we had the FQHC over here coming over doing oral exams, and we were listening to these people. And I actually listened to a gentleman sit there after he'd been through mine, which was kind of the health department's education package. And I heard him tell somebody, I know they say that charter's no good, but I think it protects your teeth. And I had to sit there and go through this whole thing about it being like coral in the ocean, and there was bacteria in there, and it was eating his teeth. And he kind of got that because he'd watched some, Explorer Channel or something. So he kind of got that, but they just have that basic disconnect that has to be reconnected. And the only way, I keep going back to, we've got to start with the kids. The adults are going to be a hard learn. It's like trying to get them to quit smoking. It's easier to prevent the smoking than it is to stop the smoking. We've got to go back to the kids, put money into the kids, and start that culture of dental care.
Amen.
Thank you.
And something that we do at Jordan Valley is we have care coordinators who are meeting with those newborn mothers, talking to them about their schedule, what they need to do to come to the doctor, and then starting right then. And when your child turns 1, we want to see them for that first dental visit. Then we try to connect with them close to that time between 9 months and 18 months to go ahead and get that dental visit scheduled for them. So that's something that we are focusing on, is that very early first visit.
Thank you. And I wonder, you mentioned culture. I'm sorry. I wonder if with patients that are limited English proficiency, what culture means and what are some of the barriers. So, sorry, go ahead.
We have that issue, and I think one of the things is having people from the community. So we have 2 dental assistants that speak fluent Russian, because who knew there was a large Russian population in Southwest Missouri? But there is.
I did.
We have dental assistants and hygienists that speak fluent Spanish, and I'm not talking like medical Spanish, because that's always my favorite. No, these people were born into the cultures and understand the culture, and so I think that's a big thing. It's not recruitment of just dental providers. It's recruitment of everyone, from the person that answers the phone to the person that is assisting to a person that may be the scrub tech in the back. And it's really bringing in those cultures from everywhere. So it's diversity in recruitment.
Thank you. And I just want to remind everybody, we have a community conversation in the afternoon. So if you have other thoughts, ideas, comments, please write them down on these sheets. We also would appreciate if you fill out the evaluation for this concurrent session. And again, join me in just applauding our speakers today. Thank you so much. And it was just a wonderful information that I've never seen before. And we're looking to, forward to the report, because that's such new data that we haven't seen. Yes, please. Thank you.